All right. So again, thank you for coming. My name is Mark Jennings. I'm the Associate Executive Director of Project Find, and I want to thank you for coming to our vaccine education event today to learn more about the vaccine and its effects. And you can always put in the chat if you like some of the reasons why you might have come, and our panelists will be able to see that as we go along. Panelists, feel free to operate in the chat as well as the presentation is going. If you see some questions you want to pick off and answer in that way, and we're going to go ahead and get started. Today's event is really we know that in the human services field, being vaccinated is a tough decision. We know that it's a new vaccine, and as we'll learn, some of the technology behind it may not be new, but it's definitely something that has come about in rapid pace, which is a good thing for COVID and how it's really affected us. And we wanted to make sure at Project Find and the Racial Equity in Supportive Housing Workgroup that we had a space where people could ask questions, could learn a little bit more information to make a very informed decision about taking the vaccine or not, or being able to help others if you're in the market of trying to help others get the vaccine. So that's one of the reasons we're here today. I want to thank our esteemed panelists for joining us. They will be introducing themselves a little bit as they begin their particular presentations. Just as a matter of format, we're going to go through the presentations and wind into a Q&A at the end of the session. And if you have some things that are coming to your mind, definitely put it in the chat, jot it down. And so we want to basically come back to that. The most important thing is the Q&A, and we want to get to your questions, etc. And we want to get the information out. We're recording the session so that it can be used in other spaces, especially for those who are not able to make it. We know, shout out to our kitchen staff that are out there serving grab-and-go meals right now and may not be able to make it today for our senior center. So we want to thank you all for allowing us to record this session so that others can benefit as well. And so without further ado, I want to go ahead and give us a little welcome, and then I'm going to hand it over to Louis to begin our presentation.
I'll just jump on very quickly. I'm Diane Michelle, and I'm a co-chair of the RESH work group. And Louis, if you could take it on.
Hold on one quick second, if I can try to do this welcome, maybe.
Oh, great.
If I can make it work.
Yeah.
Please tell me if you don't. Please tell me if you don't hear when I.
Hey, what's up? Good morning, everybody. It's Cedric The Entertainer here. Just jumped on to join you and say congratulations, one, to Project Find and the Racial Equity Supportive Housing Work Group for hosting this wonderful event. Hey, we are just coming out of this crazy pandemic. Our life has changed a lot. Now, I know I want to encourage all of the workers in New York City, those working in the housing, supportive housing workers, please get vaccinated. Go out there, get tested, make sure that you are protected from this crazy virus. This virus shut us down, not just here in the United States, but all around the world. And I know that we as a community we're very hesitant about taking these vaccines, and I understand that. A lot of history for that. However, I know that I've traveled in many places in this world, and oftentimes you have to get vaccines just to go. So we do take shots when we want to go places. So, and I think it's time as we get back out into the world. This coronavirus has caused a lot of damage, took a lot of lives, and it's a really serious thing. So please be encouraged. Learn from this event today. Thank you for being a part of it. Encourage your family, protect your family, encourage your community, protect your community. All right. Got to shout out my good friend Mark Jennings for putting this event on. And hey, everybody, y'all have a great day. Learn a little something. Let's get back out there, but let's do it safe and responsibly. All right. All right. That's real talk, y'all. I holla. Hope to see y'all in the neighborhood. You know what I mean? Monday nights on CBS. I holla, yes, sir.
All right. So again, just want to you know, there's a little fun thing to get us started, but you know, the real reason we're here is to get the information. And again, want to thank our esteemed panelists, Louis, AYANA, um, MANDISA, and Alex is another doctor who's here with us too, and may chime in if necessary. So please take it away.
Well, I don't know if I can follow up Cedric. I'm glad that he went first, though. I should probably always come after Cedric the Entertainer. So thank you all for joining us today. My name is Louis Shackelford. I am an external relations project manager at the COVID-19 Prevention Network. And so if you don't know, the CoVPN, as we call it, is the organization that is a collaboration of many government entities and research entities that have come together to shepherd almost all of the COVID-19 vaccine research that we've done in the United States. So every vaccine that's being approved for emergency use, with the exception of Pfizer's vaccine, we've shepherded those clinical trials, especially the phase 3 portions of those clinical trials. And so I'm here today to talk to you a little bit about COVID-19 and COVID-19 vaccine research. So if we can get the party started, put up the slides. And can we go to the very, very first slide with my name on it? That would be great. So also, I should let you all know that I am a born and bred New Yorker. I'm from Harlem, born and raised. I lived in Harlem almost all my life up until about 4 years ago when I moved here to Seattle, Washington to take this job at the CoVPN / HIV Vaccine Trials Network. So most of my experience in research comes from HIV prevention research, but that's another story for another time. So as I said, my name is Louis Shackelford. I am an external relations project manager at the COVID-19 Prevention Network. And so I want to get started. Next slide. So just setting a baseline of information as we get started with this conversation. So it's really important to know that COVID-19 is a disease and it's caused by a virus, and that virus is called SARS-CoV-2. And one of the biggest things for you to know about SARS-CoV-2 is the way it's shaped, and specifically one part of it, which is called the spike protein. So those little red parts that you see, those are what we call the spike proteins. Those are the parts of the virus that all of our vaccines target. They stay the same and they play a really important role in terms of how the virus infects a human cell. Next slide. So those spike proteins are what some of the scientists I work with call the landing gear of the virus. So they allow the virus to latch onto a human cell and infect that cell. And so the really cool thing about that part of the virus is that it doesn't change very often. It stays the same most of the time, or the majority of the time, as a virus copies and replicates itself in the human body. And so that's really important. It gives us a really good, really reliable target for us to make vaccines. So next slide, please. So this is another view of the spike protein, and this is how it infects a human cell. So on the left side of your screen, you have the virus and the spike protein, and then on the right side, you have the human cell. And so if you go to the next slide, you'll see that the virus SARS-CoV-2 uses that spike protein to engage the human cell and infect the human cell. But if you go to the next slide, you'll see, can you click it one more? It should be an animation. There you go. So what our vaccines do is they teach the body how to recognize this spike protein on the virus before you actually get infected. So it basically trains our body or teaches our body how to recognize SARS-CoV-2 before we come in contact with it. And so in doing that, in training the body before we get infected, it allows us to create an immune response called antibodies. We create these antibodies specific to this particular virus, and those antibodies block the spike protein from actually infecting the human cell. And so that's pretty much how our vaccines work. Next slide. So what do we know from the research? So right now we have 3 highly effective COVID-19 vaccines, those being the Johnson & Johnson vaccine, the Pfizer vaccine, and the Moderna vaccine, all approved under the emergency use authorization. So as we know, we're in a public health emergency, being in a pandemic, and so we needed these vaccines really quickly, and so they were approved under emergency use. However, they have gone through all phases of clinical trials that any vaccine would go through, and we'll talk about that more in a little bit. And it's really important to know that we didn't cut any corners, that all these vaccines went through the same process that you would normally see, and there were no corners cut. So next slide. So one of the biggest questions that we always get is how do we get these vaccines so fast? Why were they produced so fast? And so this slide is a little graphic that we created to give a greater sense of how these vaccines were developed so quickly. And so on the top, you see the normal process or the usual process that we go through of vaccine development. And then on the bottom, you see the process that we've gone through with our COVID-19 vaccines. And if you look, you see that all the processes are the same. But for the COVID-19 vaccines, we were able to overlap the processes so that we got the vaccine, so that all the vaccines went through the same stages of clinical trials, but we were able to overlap them so that we can develop the vaccine and get them out a little bit quicker. We also were able to manufacture the vaccines while the trials were still going on, which is something that's usually unheard of. Usually you don't pay for manufacturing a vaccine until you know it's effective. But in this case, it was really important that we have these effective vaccines because we knew that it was an emergency and a lot of people were dying, a lot of people were getting sick. So in advance of approval, we manufactured so that once we found vaccines that were effective, we can get them out really quickly. And then any vaccines that were found to be ineffective, if that was the case, we would just destroy them. Next slide. So another question that we get very often is, do these trials, do the clinical trials that we run represent us? How do I know that this was really representative of Black communities, of Latinx communities, of people of color in general? And so I just wanted to show you a little bit of the faces, a little bit of the people who were involved in developing and shepherding these clinical trials. So we had multiple expert panels based on which populations the COVID-19 pandemic was affecting disproportionately. So we had an African-American expert panel, and this was just a panel of African-American doctors who gave their input in shaping the vaccine trials that we had, and making sure that they were inclusive of Black people, that they were responsive to the needs of Black people, that they managed, that they understood how to get out messaging and data to Black people and engage Black people, even during the trials and after. So this is just a few faces that were there representing you in our community while the trials were going on for vaccines like Moderna and Johnson & Johnson. Next slide. Here we have our Latinx expert panelists. Again, this was a group of Latinx experts who gave the same sort of input for the Latinx community, making sure that the trials were inclusive of Latinx folks and making sure that they were responsive to the needs of the Latinx community. Next slide. And again, same thing for Native and Indigenous populations, making sure that these communities were also heard in the process. Next slide. And then again, outside of these expert panels, we had people throughout the research process working to make sure that these trials were safe, were inclusive. And these are, again, more faces working administratively, working in community engagement, working to make sure that these trials were not just inclusive of racial and ethnic minorities, but also gender identity, sexual identity. Next slide. And again, more faces, some that you may find familiar, of people who worked really diligently to make sure that you were thought about and included in these clinical trials. Next slide. So I just wanted to end it off with a little bit of data. So the last question that we get very, very often is that I want to wait and see. I don't want to be the first. I don't want to, I don't want to be anybody's guinea pig. And that's totally understandable. And so I like to put out the numbers of how many people who have already been vaccinated. So in the United States alone, about 145 million people have been vaccinated overall. And then that equates to about 50% or over 50% of the population when you look at people 12 and over, and when you look at people 18 and over. So, and just for context, the amount of doses that are administered on screen, 311 million, over 311 million doses. So when you're thinking about getting this vaccine, I hope that you know that you're not the first, that you're not nowhere near being the first, that this vaccine has been giving out to a lot of people. Across the world, we've administered 2.4 billion with a B doses of vaccine to about 20% of the global population. So there are a lot of vaccines out there. There are a lot of people getting vaccinated. And so what we see is that these vaccines are incredibly safe. They're incredibly effective. And for all the widespread distribution, we see very little side effects. Next slide. And then I'll just leave you off with some resources. So we have a Dropbox where you can find some of the infographics that I've presented today and a whole host of other information. And I can just leave this on screen at some point for you to take if you needed extra resources on COVID-19. And that's about it for me. Thank you all again for inviting me to this space. I really appreciate it. Mark, you're muted.
Of course I am. So thank you again. And I saw one question come down in the chat, and we'll come around and come back and make that our first question when we get to our Q&A, and want to move forward to AYANA to give us a little bit of encouragement and talk, and after that we'll move forward to Dr. MANDISA. and Dr. AYANA as well.
Sorry, can I just interrupt for a second? I think that everyone should kind of know who the panelists are, maybe before we do that. And if I kind of welcome everyone, Louis, you got to introduce yourself with the other two panelists. Could you just give a little brief bio and then you can go on with your presentations? You mind, AYANA, would that be okay?
Yeah, thank you, Diane. Hello, everybody. I'm Dr. AYANA Elliott. I'm a doctorally prepared nurse practitioner. I work in the field of HIV. I've been an HIV primary care specialist for most of my career, although I've worn other professional hats, including executive healthcare operations. I am originally from Washington, D.C., but I now live and work in Los Angeles, California. I'm currently a senior medical scientist for HIV prevention with Gilead Sciences. Although I'm here today on my own volition and not speaking for the company, as a nurse and a nurse practitioner, I'm very indebted to the field of infectious disease, working for the predominance in my career, serving medically underserved communities, including sexual and gender minorities. And today's topic, I think, is very important, particularly as we're talking to people who have not always had the best of access to medical care and services, and just being able to explain and appreciate what that looks like for, educating communities, not only people that are in the community, but that people that work and serve these communities as well. So thank you for the opportunity.
All right. Next.
Well, my name is MANDISA McIver. I am a pediatric emergency medicine physician. I currently work at Children's National Hospital in DC, so AYANA, DC. And I'm very excited to be here with each of you, and I'll be focusing on COVID and children today.
Great. Mark, I take it back to you.
No, we'll turn it on. AYANA, did you have anything you wanted to add in prior to turning it over to the doctors before the Q&A?
No, I think that what in line with what Louis presented, just wanted to piggyback a little bit off of the conversation around how we got here so quickly. Much of the skepticism around vaccines coming to communities has left the trepidation around uptake. And it's really important that folks understand that we were able to bring not only the research, but the actual vaccines so quickly to communities because of our nearly 40 years work on HIV and AIDS. It is the technology and the powerhouse infrastructure of HIV prevention clinical trials that laid the foundation in how we were able to bring patients or bring participants into a clinical trial. The sites, you should know, for many of the HIV vaccine clinical trials were the same sites that were used to enroll folks in the COVID-19 clinical trials. And this is not something that we often recognize as a celebration. We've looked at it with trepidation, but not really taken into account how we should be celebrating where the science is, where researchers are, and bringing all of this so quickly in a time of a lot of uncertainty, that we were able to get these scientific molecules into in a research lab, develop them, and to be able to put them into a clinical trial so quickly, and then how heroic it was that a decision was made to begin manufacturing Of course, the manufacturing didn't happen without any confidence from, the preliminary phase 1 evidence that demonstrated that these vaccines would in fact work. But to start or begin manufacturing on such a large scale was a huge risk, but it was a bet that that seemingly cashed itself in, 10, 20, maybe even more fold.
Thank you very much. And definitely we'll come back to you in the Q&A and MANDISA.
Okay, let me start sharing screen. Okay, is everyone able to see okay?
Yes.
Okay. So like I said before, I am going to focus on COVID-19 and children. So what's the latest with COVID-19 and kids? Overall, 14.1% of all COVID cases in the United States have been in children. And that number equates to a little bit over 4 million children, which is a big number. And cases are still popping up every day. Last week, or from June 3rd to June 10th, there were over 14,000 new cases of COVID in children. So we're definitely still seeing it every day. And for that week, that represented about 20% of all new infections that week, which is big. That's 1/5 of the new cases was in children. Severe illness due to COVID-19 itself is rare in younger children. However, children can spread COVID to adults who are more likely to have severe disease. And this is an important point for us to understand. Hospitalization rates for COVID are higher among Black and Latino children, and obesity in children may be a contributing underlying condition. This is important because in the US, childhood obesity is a serious issue. And in the Black community, the prevalence of obesity is 24%. And in the Latino community, in children, obesity is 25% as well. So I'm sure that many of you have heard of MISC. This is an uncommon but very terrifying illness in children with COVID. It stands for multi-system inflammatory syndrome in children. In order to be diagnosed, the children have to have had a recent COVID infection or an exposure to someone who had COVID. And then about 6 weeks after that exposure or the infection, they'll start showing symptoms. The symptoms are fever for more than 3 days and the involvement of two or more body systems. So in the emergency room, we have seen these patients. When they come in, if we are concerned about MISC, we do lab work, we do EKGs, we have subspecialists see these kids. And then if we're very concerned about MISC, these children are managed in the ICU because they can get very sick. MISC can cause low blood pressure, heart dysfunction, blood clots, and kidney dysfunction. And we're seeing this in children. So moving on to the vaccine as it pertains to the general population and then children, the CDC right now is recommending that everyone ages 12 and above receive a COVID vaccine. Over 300 million doses of vaccine have been given in the US through June 7 of this year. After the second dose, the mRNA vaccine has been shown to be 90% effective in preventing infection with COVID-19 over a 13-week period. Immunization with Pfizer or AstraZeneca was found to decrease transmission by about 50% in UK households with a mix of vaccinated and unvaccinated people. So we've all seen headlines. The headlines can be scary. And we know the history of medical care in the United States, and it's real. So we'll go through some of these and then I'll touch on a few of them. So there's the headline about a possible link between the second dose of the vaccine and myocarditis and pericarditis. Rare blood clots that were seen after the vaccine was given. whether or not we should hold off on giving the vaccine to younger kids until we know it's safe, allergic reactions. There's a book called Medical Apartheid, an amazing book that really highlights the historic and systemic racism in our country as it pertains to research and clinical trials. And it really kind of explains why people of color are reluctant to participate in clinical trials and get vaccines. One of the examples is the syphilis experiment in the Tuskegee Airmen. Here's one headline where it says hospitals on lockdown as the first COVID vaccine patients start eating other patients. And this is just an example of like the anti-vaccine propaganda that really can deter us and get us off course and make us nervous and scared. So the important thing is, as we see these headlines, we hear these scary things, that we really try to break down the numbers and understand what it means. So we'll take myocarditis. It's one of the more recent headlines, myocarditis that's seen in young adults. And basically between December 2020 and May 2021, in Israel, they reported 148 cases of myocarditis, which is inflammation of the heart muscle. It can cause chest pain and shortness of breath, fever, fatigue. And mostly it's mild and self-resolving and is treated with anti-inflammatory medications. So they reported 148 cases during that time frame. Most of them were young adult men, and they were seeing it after the second dose of the vaccine. Overall, during that time period, Israel had 275 total cases of the disease. So if we look at that time period where they reported myocarditis, at the same time, they had over 5 million Israeli citizens that had been vaccinated against COVID. So when you do the math, the rate of myocarditis in Israel at that time period was 0.005%. And that's just assuming that all of those cases of myocarditis were from the COVID vaccine, which that's not been proven, but we'll just say worst case scenario, 0.005% rate of myocarditis in vaccinated citizens in Israel. We have to weigh that against the rate of death from COVID in the US, which is 600,000 people who have died out of 33 million infected people. So the rate of death from COVID in the United States is 1.79%. And for Blacks, it's double, 3.4% of death rate from COVID in the United States. So your risk of dying from COVID is over 300 times higher than your risk of even contracting myocarditis from the vaccine. So this is one of the ways that you kind of have to, when you hear the numbers, you have to really sit down and break it down and try to understand, what does this mean? On top of that, let's say you actually get COVID or that your child gets MIS-C. Either of those can cause myocarditis. So you have a risk of getting myocarditis just from getting COVID and MIS-C. The other headline that we discussed was blood clots. Johnson & Johnson and AstraZeneca vaccine rollouts were paused because they found 38 cases of blood clots in young women after the vaccine. So again, we'll break down those numbers. The rate of blood clots in these vaccinated women, 38 women, was 0.00015%. If we look at the general population of women in childbearing age, their risk of blood clots is 0.04%. And that's over 200 times higher than if they had been the rate that we're seeing with the vaccine. The risk of blood clots in women using birth control is even higher. It's 0.07%. So that's over 400 times higher than the risk of getting the blood clot with the vaccine. And then the risk of blood clots during pregnancy and during the postpartum period is 0.2%, which is over 1,000 times higher than the rate of blood clots with the vaccine. So again, just important to really look at these numbers and understand what it means for us. In addition to that, if you get COVID, there's a 2.1% rate of getting a blood clot. And that's over 13,000 times higher than the likelihood of getting a blood clot with the vaccine. And if your child gets MIS-C, they have a 6.5% rate of getting blood clots, which is over 40,000 times higher than the rate of getting a blood clot with the vaccine. In that study with children, the children who had COVID and MIS-C and were hospitalized, they had a 30% death rate as well. And this is with getting COVID and MIS-C. So in general, there are going to be a lot of questions because again, this is a new virus. The vaccine is new. There's still a lot that we need to learn. So the effectiveness of the vaccine at preventing the spread of COVID, early results in the research are very promising, but we don't have exact numbers. How vaccines will perform against COVID-19 variants. I'm sure everyone has heard about the mutants, the different variants. That's something that researchers are continuing to look at. Also, how long the vaccine will provide immunity. At this point, early results are suggesting at least 1 year of immunity. We're also looking into how effective the vaccine is in smaller kids. And right now, trials are underway for kids aged 6 months through 12 years. And we're also looking at immunocompromised people and how they'll respond to the vaccine at all, and whether vaccination of immunocompetent people will protect our neighbors with cancer and chronic steroid use and HIV and other immunocompromised illnesses. So in summary, I wanted to show this graph because I find it very encouraging. The red line is the number of daily new cases of COVID. And the blue line is the number of vaccine doses administered. And you see, as we increase the number of vaccine doses, you see a decrease in the number of COVID-19 cases. I find that very encouraging and promising. And in summary, the benefits of the COVID-19 vaccine far outweigh the known and potential risks. It's important that you use reliable sources for data and information. For children, you can look at the AAP website, which is the American Academy of Pediatrics, where the CDC also has updated data. And by vaccinating children, we can contain the virus and decrease the spread. Thank you very much.
So thank you very much, everybody. And I'm going to turn it over to Diane. And you might have to introduce yourself, Diane, as well.
That's right. Yes, I will. I tried to do a quick introduction.
Yeah, and Diane will carry us through our Q&A. Thanks very much.
Hello, everybody. I'm just going to start with my introduction. I'm Diane Gawd Michelle. I am the Executive Director of Lantern Community Services, New York-based supportive housing agency, and I'm also a co-chair of the RESH, Racial Equity and Supportive Housing Workgroup. So I just wanted to say, want to start off, I have a couple of questions in the queue, but I just want to start off because I've been on a lot of different presentations about the virus, and I have to say we do have a vaccination task force within my agency, and the uptake among staff and clients has not been stellar. We're not even at the 50% rate among either of those cohorts, and I feel that there's been a kind of fatigue about how much more is education going to advance the vaccine confidence. But I've been on so many of these things, and I found today's, the spin, the information, the focus on both the vaccine itself and its efficacy, its impacts on Black communities, it was packaged differently than other things that I've seen. So I found it very effective. And I just want to say, hope everybody can give our panelists a round of applause, including Cedric, who kicked it off for us. I found it to be really, really effective. Now, I do want to say that there are a couple of questions in the chat. One of the ones that I thought we should maybe start off with, and maybe Louis, you could also help, was there was a question about how the composition of the clinical trial participants was sort of shaped and then also determined. So we went through like the expert panelists, but could you tell us a little bit more about diverse communities' participation in the trials?
Sure. So the clinical trials were comprised of volunteers from communities throughout the United States. And so they weren't necessarily, I wouldn't use the word determined in that instead what we did was we cast a broad net to people throughout the United States, throughout communities throughout the United States, to come and be involved in clinical trials. And particularly, we did that through all sorts of advertising, community outreach. We have research sites throughout the country who are conducting in-person outreach as much as possible, because remember, this was, again, in the middle of the pandemic when a lot of these trials were fully enrolling. And so most of the trials did a really good job in terms of enrolling diverse populations. I know that the clinical trials that were directly associated with the COVID PN did a stellar job in terms of enrolling diverse numbers of people in the clinical trials. But the composition of the clinical trials was shaped really by the volunteers who went out of their way to make sure that these vaccines were safe for everyone.
May I ask one other kind of follow-up question? So if there were a broad diversity of participants in the clinical trials, were the impacts of the efficacy similar across all sort of racial, gender, sort of subpopulations and subgroups?
That's a really good question. And I would say from all the data that I've seen, there were no specific differences between races or people in the trials, genders. Yeah, the vaccines were really effective across all populations. And that was one of the amazing things that came out of the trials.
Okay. Thank you very much. I wanted to just put that point of clarification. There was another question that I want to put out, and I can put out to more than one. And so I'm scrolling through the Q&A. Are there any categories of adults who maybe the physicians and nurse educators, doctors on this panel would say are not recommended to receive a vaccine? Are there any sort of people that should be carved out or should seek deeper medical advice from their primary care physician before getting a vaccine? I do.
Hi, I'll go ahead and take that one. My name is Alexandra Rucker. I'm also a pediatric emergency physician at Children's National. Also a DC native, went to high school with Mark. So happy.
Yeah, I saw you over there. I wasn't sure whether I was going to call you out.
No, I know. Happy to be invited. No, Mandisa put her foot down. So the only people that should not get the vaccine are people who have a known severe allergic reaction to anything that's in the vaccine. And so when I got my vaccine, they gave me a paper with all the ingredients for each vaccine on it. And so if you have had a severe allergic reaction to any component of that vaccine, then you shouldn't get it. That's it. Of everybody 12 and over who doesn't fit that criteria should get it. There was some question in the beginning about whether people who have had severe anaphylaxis to anything should get the vaccine. And that recommendation has been dispensed with. I have severe anaphylaxis to a few things, and I carry my EpiPen with me just for good luck. When I got the vaccine, I had no issues. And similar to blood clots and similar to myocarditis, the rate of anaphylaxis from the vaccine has been exceedingly low. And to my knowledge, there have not been any deaths from anaphylaxis at all from the vaccine. So the only people who are recommended to not get it are those people who have known allergic reactions to anything in the vaccine. And that's it.
I think that's very helpful.
And I just want to say that Alex has been very humble. She's an assistant medical director of Children's Hospital in Washington, D.C. as well. So just to let you know as well.
Oh, this audience, okay, thank you very much. This audience is really on this, like the vaccine, okay? So another question came through, said if a person has had COVID and still has a high level of antibodies, is it still as critical for them to get the vaccine? I've heard that question before in other forums. So if you already had COVID, you still have a high level of antibodies, always presumed, should you kind of like lay back in the cuff and wait for some indeterminate amount of time?
So I put an answer there that if you have,
I missed it.
Can you hear me? If you have, if you actually have the COVID infection, that provides what we call natural immunity. And at this point, we really don't know how long you will be immune to COVID and how long those antibodies will last. And also, as we know that this virus mutates, we don't know how long those antibodies will cover you for the mutants. And so at this point, it's still recommended to get the vaccine after you've had a COVID infection.
Thank you. I'm sorry. I was scrolling methodically through the chat and get to your answer. Got another question. Question, if there were other pending studies on transmission rates from vaccinated people besides the AstraZeneca. So like, you know, you've been vaccinated, you might still be able to transmit COVID to somebody, to another person, an unvaccinated person. Any other research that you know that's pending or results?
Yeah, that's a good question. So it's really important to know that the first trials that we had really looked at the effectiveness of the vaccines in preventing severe disease and preventing death. So when we look at those numbers that are presented around efficacy of the vaccines, we're looking at vaccines that were, those numbers came from trials that were designed to give us information about how well these vaccines prevent people from getting sick enough to go to the hospital, and how well these vaccines prevent people from dying of COVID-19. And so that's what these vaccines have been shown to be extremely effective at. They're extremely effective at doing both things. And so now there are some clinical trials underway to look at how effective these vaccines are in reducing the spread of COVID from person to person. And so the COVID-19 Prevention Network has a trial that's called COVID-U, that's enrolling people from universities across the country, trying to see or look at how COVID spreads and how effective these vaccines are at reducing the spread of COVID-19. So that's just one trial that I know of off the top of my head. I know that Moderna, Pfizer, all of these companies are looking at this as well in clinical trials. So yes, that question is being examined right now.
Awesome. Thank you. I feel like there's so many questions. I have some of my own, but I didn't want to give sort of an opportunity. One of the things that fascinated me about this presentation was the very explicit link between the decades of research into AIDS and that being a virus that also had public health implications, right? Epidemiological implications. I kind of wanted to ask AYANA if she's been seeing, given that she's done a lot, she's been in that space for a while, she's also been seeing things in the LGBTQ community as sort of that outreach. You know, are you seeing anything that you want to comment about vaccination rates, especially on the LGBT community, Q community, and anything else that you're seeing in your experience with the vaccination and with community engagement around the vaccination that you'd like to share?
Yeah, thank you, Diane, for that question. I think that there has been sort of a delay of marketing or communication to people who identify as LGBTQ+. We know from long time history around anything when it comes to public health that it's important that we have messaging and communication that is reflective of folks' experience or communities. And that lack of communication directly to this particular community around COVID didn't come to us as quickly as we would have liked, but it is there. There are a number of organizations that have put together campaigns that would educate folks about the vaccine, same as we're doing here, with some introspection around the fact that, you know, gay, bisexual, transgender people, you know, people in this community have, this is not their first time of dealing with a plague of sorts. Again, you know, we just hit the 40-year mark of HIV and AIDS. And so having the experience, you know, it's in folks' in their DNA, it's in their mindsets that they survived as a community this plague from the early 80s that was said to take them out. Having that resiliency is something that we've been able to sort of catalyze our messaging around COVID prevention and being able to get past this particular pandemic that came to us in 2020.
I know that I have just my own agency's experience is that we have uneven uptake amongst our clients, but the two target populations that are the most vaccine confident are populations that are HIV positive, and I'd say the second one are the people who are living in our shelters or in our more congregate supportive housing, like SRO, concrete supportive housing. There's a definite distinction between their uptake of vaccine confidence and our youth who don't, our young adults are like, yeah, it's not gonna happen, not gonna affect me, don't worry about it. So I think I'd love to be able to explore that connection with them and sort of their lived experience with HIV or with other kinds of public health issues.
Yeah, it's different buckets. So all three of those groups are three separate entities that you have to deal with on a different level, being able to meet, appreciate where they are and what their perspectives are on preventative health and wellness. Health-seeking behaviors is something that I've studied for a long time, particularly in sexual minorities, around people's perspectives in, you know, how they go about engaging in healthcare. Again, we haven't had a great history of treating these folks very well in the healthcare setting. So let it not be a surprise when we come to this particular crossroad of this pandemic, where you want them now to go and see somebody about getting a shot. We're not even going to talk about people's fear of needles and the rejection of Western medicine, but just saying, when you have, you know, educated me about the safety around these vaccines, and I'm you know, accepting and I'm willing to engage or uptake, I go into this clinic and they treat me like crap. You know, they call me out of my name. They look at me with dismay. There's a lack of appreciation of my experience or how I present. I just think about, you know, people of transgender experience, what that would be like for them to go into a place and, you know, you have not recognized me in my authenticity as I present, and how the whole interaction is just marred. I am always cognizant of that. It might not just be that I have skepticism around this vaccine, but I just don't want to go to your doctor because your doctor doesn't know how to respect me.
Yeah. Okay. So I know we're approaching the hour. I just want to ask a quick question about the Delta variant. A lot of people are asking whether the current vaccines are helping against the new Delta variant? And I know that's come up, but anything specific to this latest one?
Yeah, the Delta variant is becoming very prominent in England, in the UK. And so that's where lots of the studies have been done, and have included in this latest study from Public Health England, over 14,000 cases of the Delta variant. And for the Pfizer vaccine, the efficacy is still in the 90s. It went down a bit for the AstraZeneca vaccine to about 79%. But they have, that variant has been included in the latest effectiveness research, and we're still okay there. It may become a thing later on that because this virus mutates a little bit, a little bit at a time, that it's going to have to be sort of a combo vaccine like we do with the flu vaccine every year, and we redo the variants every year. We don't know that yet. So there's that. And then I just want to address very briefly the allergy situation. Yes, so when they did the studies in kids 12 to 15, there were no reports of serious allergic reactions, and that was in with the Pfizer and Moderna. And in the adult studies, the anaphylaxis cases were still, 1 to 3 per million. And again, anaphylaxis is something that we have pretty good treatments for. Even though it is a life-threatening situation, we have pretty good treatments for it. COVID, we have treatments for, but there is still a 1 to 3% death rate if you get COVID, despite our best efforts. So there's always, risks to be weighed. But if you ask me if I wanted COVID or if I wanted to have anaphylaxis, I would pick anaphylaxis all day, because I know that I have a decently better chance of coming back from that with treatment than I have with COVID. That's just me, but and I've had anaphylaxis at least 4 or 5 times, so I know what I'm talking about with that. And but the anaphylaxis rate with this is exquisitely low. Would I take my EpiPen to the vaccine? Yes, but I take my EpiPen everywhere. So yeah.
There you go.
Yeah.
One, I know that we are pushing the hour. I just wanted to get one other thing, which I thought was interesting, and I want to make my closing comment before I hand it back to Mark. Someone asked, given how sort of the AIDS research has helped inform the COVID vaccines ability, especially the mRNA, someone asked, how far are we from developing a vaccine for AIDS? I'm throwing that out there.
I can say that HIV vaccine trials are ongoing. That's one thing that I do with my other hat, my HIV vaccine trials network hat. So there's actually an ongoing study right now called the Mosaico study that looks at a vaccine that targets different parts of the HIV virus. And that study is currently enrolling across the United States, South America, and Africa, and Europe. So we still have a long way to go in terms of HIV vaccine research, but we've made progress and things are developing. So stay tuned.
Oh, that's great. Okay, so I know people have to jump off. My closing comment was something that I heard on NPR, but I'm an NPR junkie, last night or yesterday. And it kind of summed up what I've been thinking about just in terms of my own. I'm very pro-vaccine, but I'm also very pro-community. And I kind of think about not just my individual reasons, I have a host of them, but I'm always concerned about, like, when is the community going to get back to normal? When are Black and brown people not going to be disproportionately and disparately harmed by COVID? And it just said that the pandemic is over for those who are vaccinated, and the pandemic is still raging for those who aren't. So it gave me something to think about. All right, I'm going to kick it over to you, Mark, to close us out.
And so I know some of our panelists are off to work. I mean, I'm thanking them for sort of squeezing us into their busy days. And Diane, thank you very much for your time and effort in helping us put this together. Project Find, David, so our executive director, definitely want to thank you for your leadership and
my good friend
in helping us as well. So, and again, we'll have this recording up so that others can gain this information. And I want to thank you all for coming. And lastly, the Racial Equity in Supportive Housing Work Group. I want to thank everyone who's participating there. We have another event in RESH, just so you know, an event where we are doing a showcase. So if you have any youth ages 8 to 24 who do any spoken word, rap or song, there's information for that, and we'll get that out to you as well. And without further ado, want to get the raffle sort of going, and I'm gonna stop recording for that. So long to the internet, and hello to the raffle folks.